Hi, my name is Janae Patterson, and I'm in N415, Research and Evidence-Based Practices. This is a presentation for the signature assignment of the class, and I've been asked to reflect on a clinical problem that's been identified in an area of clinical nursing. This presentation summarizes the clinical problem, research, and knowledge available related to the implementation of a practice change in the clinical practice environment. So the clinical problem that I chose has to do with some things that I've learned during our virtual clinicals. Although we haven't been in person in the hospital to experience many of the adult health courses, I have noticed some things in our virtual clinicals and simulations and along with discussions with professors. And one of the things that has really stood out is that many of my med-surg patients, primarily those who are post-op, end up going septic and need to be transferred to the ICU. In these clinical rotations, I've seen that there is a great need for nurses to be aware of the risk of sepsis on any floor, not just the ICU. And we've seen that in the ICU there is a great focus and awareness of sepsis. However, in other floors it's kind of lacking, and many times patients go undiagnosed with sepsis until it is very obvious, and they then need to be transferred to the intensive care unit. Considering the poor outcomes associated with sepsis, I became very interested in the subject and wanted to see if there are any protocols or quick assessments established that can be implemented to improve patient outcomes in floors other than the ICU. So to quickly define what sepsis is, the Third International Consensus Definitions Task Force defines sepsis as the life-threatening organ dysfunction due to a dysregulated host response to infection. According to the Sepsis Alliance, which is a really great resource for all things sepsis related, especially patient education, sepsis is the leading cause of death in hospitals, and the risk of dying from sepsis increases by as much as 8% for every hour treatment is delayed. That statistic alone is enough to warrant need to find ways to quickly assess for signs of sepsis and make that known to providers so that this can be prevented. So as sepsis has been studied over several years, many protocols and tools have been developed to be able to recognize signs and symptoms as well as to diagnose. And one of those tools is the SOFA scale, or Sepsis-Related Organ Failure Assessment Score. So as you can see here, the SOFA scale is quite extensive, rating partial pressure of oxygen, platelet counts, bilirubin, MAP, or use of vasopressor drugs, Glasgow Coma Scale, and creatinine levels along with urine output. Depending on the levels for each category, it is assigned a score which then adds up to the total score. Although this is for providers to use for diagnosis, as a nurse it's always good to be on the lookout for potential signs of sepsis, and so the TIME acronym is helpful for this. As you can see here, this acronym represents watching if the patient has an abnormal body temperature, signs of infection, mental decline, or if they are extremely ill, can all indicate potential signs of sepsis. So with this SOFA score, an acute change of more than 2 sepsis-related organ dysfunction assessment points would identify sepsis. But that score requires multiple laboratory tests and may not be available in a timely manner, and so to facilitate simple recognition in a pre-hospital ward and in the emergency department, the task force recommended a prompt called QSOFA, or Quick SOFA, for Quick Sepsis-Related Organ Dysfunction Assessment Score. As you can see here, QSOFA can be easily obtained through basic assessment data for patients who are suspected to have an infection. The criteria points in this score is altered mental status with Glasgow Coma Scale less than 15, tachypnea with respirations greater than 22, and hypotension with a systolic BP of less than 100. By familiarizing nurses with the QSOFA criteria, providers can be alerted sooner rather than waiting for lab results in order to get further evaluation from providers and start sepsis bundles sooner. In order to operationalize and implement this new policy, I would first begin by conducting a survey of nurses on a specific unit floor such as med-surg, and have a survey focus on how comfortable the nurses feel recognizing the signs of sepsis in patients and then informing the provider of these findings. Using national benchmark rates as a baseline, methods can be implemented to measure the subjective side, being how comfortable the nurses feel in their ability to recognize signs of sepsis, and then conduct this survey prior to having the nurses complete a CEU regarding the QSOFA method. An exit survey with the same questions as before will be used to evaluate learning from the education presented. And so this is done because the nurse will be the one who first encounters these signs through basic assessment data and can greatly reduce the amount of time between recognizing signs and the patient being diagnosed with sepsis by using the QSOFA method and quickly alerting the provider that the patient has met some of the criteria and needs to be assessed by the provider for further evaluation. Some barriers to this method could be that not all nurses will be completing CEUs at the same time due to individualized licensure renewal dates. So the solution to this would be that the data will need to be collected over an extended period of time, preferably a year, to get a data set that reflects a greater sample size of nurses who have completed and have begun implementing the education received. Due to the nature of the study where nurses will be the ones surveyed versus patients, I don't feel that there are any ethical considerations, considering that the data of patients who have been diagnosed with sepsis will be anonymous to the studiers, and no personal information will be revealed in that process. The only other thing that will be involved is that the nurses will be completing their education modules due to their requirements for licensure, which is something that they're required to do anyway, and so they most likely won't even be aware that they're part of a survey. The nursing theory that is influencing this proposed study is Ernestine Weidenbach's Helping Art of Clinical Nursing. I chose this theory as the basis for implementing the QSOFA assessment into med-surg floors because the theory really focuses on the goals of the study, which is to improve patient outcomes overall. So in an article, Weidenbach conceptualizes nursing as the practice of identification of a patient's need for help through observation of presenting behaviors and symptoms, exploration of the meaning of those symptoms with the patient, determining the cause of discomfort, and determining the patient's ability to resolve the discomfort, or if the patient has a need for help from the nurse or other healthcare professionals. Nursing primarily consists of identifying a patient's needs for help. If the need for help requires intervention, the nurse facilitates the medical plan of care and also creates and implements a nursing plan of care based on needs and desires of the patient. In providing care, a nurse exercises sound judgment through deliberative, practiced, and educated recognition of symptoms. And that definition came from an article reviewing this nursing theory. So I believe that through the use of QSOFA, nurses will be able to better exercise sound judgment and be better able to recognize symptoms of sepsis along with the patient's need for help. And so that is a basic overview of what the study would look like. Thank you for your time.